Hi everyone, welcome to our module on skin tumors and tumor-like lesions. This is a very important topic because it combines clinical recognition with pathology. So in exams, we often get tested with a lesion description, sometimes with an image, and occasionally also with histopathological findings. So our main job is to identify whether it's a benign or a pre-malignant or a malignant lesion. So now in this video, we're going to discuss on those key distinguishing features between different kinds of skin tumors and also try to understand how to recognize patterns in USMLE questions. Before beginning with the video, I would like to request all of you to subscribe and keep supporting. This lecture series is provided free and is open access for everyone. If you find it useful and wish to support its development, you can do so with the link that's on the screen and that's also pinned in the description. You can contribute to us with any of these payment methods. Skin tumors can be broadly divided into three main categories: benign tumors, which do not invade or metastasize, pre-malignant tumors, which have the potential to progress into cancer, and malignant tumors, which can invade and spread. The key point is that diagnosis is not based on a single factor. We need to combine clinical appearance and histology because sometimes lesions can look similar clinically, but they behave very differently. Whenever you see a skin lesion, we need to follow a structured approach. First, we need to observe the clinical appearance, the color, shape, borders, and surface. Secondly, we need to consider risk factors, especially sun exposure. Thirdly, we need to understand the histology pattern, like what is happening at the cellular level. And finally, we need to identify prognostic markers, like what determines the outcome. So this stepwise thinking of clinical appearance, risk factors, histology, and prognostic markers is exactly how the exam questions are designed. So whenever a question is asked on dermatological lesions or skin tumors, you need to follow this stepwise approach. Now let's start with the classic benign lesion, seborrheic keratosis. So these lesions have a very characteristic appearance. They look like they are stuck on skin surface like the wax. So that is the reason they are called as stuck-on plaques. Histologically, they contain keratin-filled cysts, which are called as horn cysts. These lesions are completely benign and are very common in older individuals. So if you see a waxy stuck-on lesion, we need to think of seborrheic keratosis immediately. Now, here's where things become clinically interesting. So, if a patient suddenly develops multiple seborrheic keratosis, this is not a normal thing. So, when there are multiple seborrheic keratosis, we need to call it a Leser-Trélat sign. This is a paraneoplastic phenomenon, meaning it is associated with an internal malignancy. Most commonly, it is linked to gastrointestinal cancers, especially adenocarcinoma. So, this is not just a skin finding, it's a warning sign of a deeper disease. So, sudden onset of many lesions, we need to think of an internal cancer, most possibly gastrointestinal adenocarcinoma. Angiomas are benign tumors of blood vessels, so these are common and are usually harmless. The two important types that we need to know are the cherry angiomas in the adults and infantile hemangiomas. So even though both are vascular lesions, their behavior is very different. Cherry angiomas are seen in adults. They appear as small bright red lesions and they do not regress, and they persist throughout the life. Whereas infantile hemangiomas, on the other hand, appear early in life. They grow rapidly initially, but then they undergo spontaneous regression over several years. So the key difference is cherry angiomas persist, whereas infantile hemangiomas regress. So this is a classic comparison. Now we move to a pre-malignant condition, actinic keratosis. This is caused by chronic exposure to sunlight. So clinically, these lesions feel rough like the sandpaper. So this tactile description of sandpaper like papules that are rough is very important. These lesions have the potential to progress into squamous cell carcinoma. So they represent a warning stage before the cancer develops. Whenever there's a question mentioning rough lesions on sun-exposed skin, you need to think of actinic keratosis. There are three major types of malignant skin tumors that we need to know. The basal cell carcinoma, which is the most common malignant skin tumor. Then comes the squamous cell carcinoma, which is more aggressive, and melanoma, which is the most dangerous due to its ability to metastasize. So most exam questions revolve around how we distinguish this BCC, SCC, and melanoma. Basal cell carcinoma is the most common skin cancer. It is strongly associated with sun exposure. Clinically, it appears as a pearly, shiny nodule. So we often see small blood vessels on the surface of the nodule. Uh, this is nothing but telangiectasia. So the edges are rolled and they're meaning that they're raised and are curved. So the classic description is pearly lesion with rolled borders and visible blood vessels. On histology, basal cell carcinoma shows nests of cells that resemble basal cells of the epidermis. At the edges of these nests, the cells line up in an organized pattern, and this is called as peripheral palisading. We may also see separation between tumor cells and the surrounding tissue, and this is called as the retraction artifact. Palisading is the key buzzword whenever a question is about basal cell carcinoma. Squamous cell carcinoma is associated with sun exposure, immunosuppression, and certain toxins like arsenic. Clinically, it presents as an ulcerated, crusted lesion that is red in color. It is more aggressive than basal cell carcinoma and is higher and has and also carries a higher risk of spreading to the adjacent tissues. So if you see an ulcerated red lesion, we need to think of squamous cell carcinoma. On histology, the key feature is keratin pearl formation. So there are circular collections of keratin that are produced by the tumor cells. We may also see bridges between the cells indicating strong cell-to-cell connections. So keratin pearls are the most important clue in squamous cell carcinoma, whereas when it comes to basal cell carcinoma, it's peripheral palisading with a retraction artifact. Melanoma is the most dangerous skin cancer. So to recognize it, we use the A, B, C, D, E criteria. A stands for asymmetry, B stands for border irregularity, C stands for color variation or multiple colors, D stands for diameter greater than 6 millimeters, indicating that they are larger in size, and E stands for evolution over time. So the most important feature is evolution. So the most important feature of melanoma is change over time. So the ABCD criteria stands for asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolution over time. Melanoma cells arise from melanocytes, so they often test positive for specific markers like S100. The most important prognostic factor is the depth of invasion. So this is measured as Breslow thickness. Breslow thickness. So the deeper the tumor invades, the worse is the prognosis. So the depth equals the survival. So this is really critical. This slide is purely high yield and purely exam gold for everyone. So each cancer has a signature pattern. Basal cell carcinoma, it's peripheral palisading and retraction artifact. For squamous cell carcinoma, it's keratin pearls and intercellular bridges. And for melanoma, it's atypical melanocytes along with a junctional spread. So if we recognize this pattern, we can definitely answer questions instantly and immediately. Some skin findings indicate internal malignancy, so these are called as the paraneoplastic syndromes. They act as external clues to hidden cancer. So dermatology becomes a window to systemic diseases also. It's not just a cutaneous thing, as we have discussed till now many times. It's not something that's only cutaneous. It's an indication for systemic illnesses. Each condition is linked to a specific cancer. For example, acanthosis nigricans is linked to the gastric adenocarcinoma. Sweet syndrome is linked to acute myeloid leukemia. Leser-Trélat and could indicate gastrointestinal adenocarcinoma. Necrolytic migratory erythema is linked to a pancreatic tumor like glucagonoma. Erythema gyratum repens might indicate lung cancer. Basic syndrome might indicate upper aerodigested squamous cell carcinoma. So these associations are frequently tested on the exams. So the most important of these are the lesser Trélat sign, which is very high. The entire topic is something that comes down to recognition. So let's try to quickly summarize and revise the key findings from the entire module. So whenever there's waxy stuck-on lesion, so it could possibly be a benign lesion like seborrheic keratosis. Whenever there's rough sun-exposed lesion, then it could indicate a premalignant lesion like actinic keratosis. Whenever there's pearly lesion along with peripheral palisading on histology, it could be basal cell carcinoma. Whenever there's ulcerated lesion along with keratin pearls, it could indicate squamous cell carcinoma. Whenever there's changing pigmenting lesion, that's showing evolution over time, so it could be a melanoma. So to assess the prognosis in melanomas, we can use to assess the depth of invasion using the Breslow method of in the depth of invasion, like till what level of the skin layers did the melanoma expand to. So these paraneoplastic signs like Leser-Trélat sign, Sweet syndrome, Basic syndrome might indicate internal malignancies. Uh, I'll be right back with a video, the last video of our dermatology series. Till then, I would like to request all of you to subscribe and keep waiting for the next video. Thank you so much. Bye.